So this is X-ray chest frontal projection of a skeletally mature patient. It shows cardiomegaly is noted, and there is cardiomegaly is noted, and there is some right-sided pleural effusion is also noted, and there is
all right, so you see cardiomegaly in a young patient. Do you know this is an AP view or a PA view? You never asked.
So this seems to be an AP view because they are.
So what else? So what differential diagnosis come to your mind?
So if there is cardiomegaly,
it's your case. So I'll wait for you to decide.
So the aortic arch, the descending aorta, it seems dilated. And so there is mild pleural effusion is noted on the right side as the pleural, as a costophrenic angle, it appears blunt. And
all right, so let's finalize it. So what else? Do you want to do anything else in this case? What would you tell the patient has on the basis of enlarged heart shadow, pleural effusion as you mentioned, and possibly plus minus aortic dilatation?
So I will go for or advise for echocardiography.
Okay, and the echocardiography comes out to be unremarkable. Okay, how strongly do you think there is an aortic dilatation? Is there any, or there's no, or you just think it is?
It is.
There is?
Yes, sir, I think it is.
Okay, and do you think that's an important finding?
Yes, sir, that might be if the patient might be having, so if it is tall patient and then can be morphism having.
Okay, let me just add something. First of all, I don't think this patient has it's an apparent borderline prominent heart, but the heart is not, there's no cardiomegaly. Because this is a poor X-ray, not a very good one. You think that the right side, there's an opacity there, and you think there is pleural effusion. But if you see this patient has slight rotation, and that can look like pleural effusion. So there is no pleural effusion. Now you can see a prominence of the aortic knuckle, and there's a bulge there. That bulge is a true bulge. Okay.
Yes,
the question is, you have to go further than that. If you think this is a bulge, do you think this is an aneurysm, or this is something else?
Yes, sir. Yes, I got it now. So there is rib notching is noted at the inferior margin and bilateral sides extending from fifth, so from third rib onwards.
All right. So you see there's rib notching. There's rib notching here. Yes, just so that's the most important finding. If you pick up this rib notching in conjunction with this aortic indentation or a figure of 3 sign, and then you correlate it with the reduced exercise tolerance, you would then come up straight to the point that this is a case of this takes a
coarctation of aorta.
Coarctation of aorta, and you must mention there is superior rib notching or inferior rib notching. This is for all the participants. When you say rib notching, you don't stop there. You have to mention superior or inferior. In this particular case, is predominant, clear-cut inferior rib notching. I can show you other cases like these ones, in which there is a small aortic knuckle. You see this one, and there is a slight figure of 3 sign here. The rib notching in this particular case is very subtle, very subtle.
Yes, sir.
All right. You can see the classic figure of 3 morphology here, just like this one. And then this is a CT scan of one of the patients with coarctation of aorta. You can see exuberant collaterals in the chest wall, and this is just to bypass the nerving which is seen because of the coarctation and focal area of nerving, proximal and distal to that side. So collateral pathways develop through internal mammary arteries, long thoracic, intercostal, spinal, vertebral, superior epigastric arteries, right?
Yes,
okay, that was the case. Now, if you dig deep into the case, the question is, what other differential diagnoses? Let's say it's not a case of, if you don't see rib notching and you see figure of 3 sign, what else comes to your mind? So the differential diagnosis, I'll take it from here because we're short of time. So if you don't see rib notching, that means the collateral pathways are not well developed. That means there's something else going on. And always consider the case of pseudocoarctation of aorta, as in this case. Now, the pseudocoarctation of aorta is rare, and it's characterized by kinking, buckling of the descending aorta at the level of the ligamentum arteriosum. And the important thing is it does not have the pressure gradient as you see in case of the coarctation of aorta. And usually can be seen in cases of the patients with atherosclerosis. But the important thing is dynamic stenosis is not there. Another differential to consider in these cases with this figure of 3 sign or bulging or kinking is an interrupted aortic arch. This is a further rare anomaly. There's separation between the ascending and descending aorta, and sometimes the connection is very, very tight. But these patients usually will have a ventricular septal defect or patent ductal arteriosis. So in this particular case, this is a case of interrupted aortic arch. This is a pulmonary artery, and you see the descending aorta is arising from the pulmonary artery, and it does not seem to have any connection with the ascending aorta. Right? Another differential to consider in such cases will be Takayasu, and Takayasu is an arteritis, as you know. The best diagnostic clue in case of Takayasu will be thickening of the large vessels and its branches. So sometimes it looks exactly similar to coarctation, but Takayasu is more common in females, almost a ratio of 8:1, while coarctation is more common in males. And always consider chronic cases of thoracic aortic aneurysms where there might be a sudden narrowing. This is a case where there are 2 secular aneurysms.
This is the X-ray frontal projection of the skeletally immature patient or mature patient, in which I can see that there is some calcified nodules are apparently present bilateral lung regions. Also, along the right lung middle zone, there is well-rounded opacity is seen. The cardiac shadow appears normal. CP angles are well observed. The mediastinum appears normal. The underlying bones appears normal. This opacity, which I see, is well rounded, and also some cysts cystic lucences. These are seen in the right.
Hold on. Right, I'll stop you there because you will go away from your main finding now. Stick to your finding and tell me what's your differential diagnosis, or what do you think this is?
Yes, sir. Sorry.
So I said, just stick to your finding, the main finding that you explained, and mention a differential diagnosis or a diagnosis based on your findings.
Sir, that opacity, well-rounded one, which I mentioned, sir.
Yes.
Sir, I will say it as a solitary pulmonary nodule with well-defined margins. And
okay. So I'll stop you here. Now, this is why I put up this case for you, because some people will call this as a solitary pulmonary nodule. Now, companion findings are very important to look for. When you see one abnormality on an X-ray, you always look for others. It's called satisfaction of survey. So you survey and you survey the adjacent bone. You see the adjacent bone. You see, we just saw a case. Did you see the previous case? Were you there?
Yes, sir. The adjacent rib, it appears somehow sclerosed and thinned out. It is not well corticated, sir.
It is not very sclerosed, but it is
thinned out,
slendered, and it is notched. You see, it is notched, clearly notched. This, look at this border, yes, and then look at this border. So if you see a notched rib with an adjacent lesion, do you think it's a pulmonary lesion?
No, sir. Then no.
Yes, because that's very important. If you see this finding, that means it's extrapulmonary finding, rib with associated. What is underneath the rib anatomically? What runs underneath the rib?
So pleura?
No, pleura is inside to the rib. But what is beneath the rib?
Beneath,
you know, when we do pleural tap, we always say avoid under the lower margin of the rib.
Yes, sir. Neurovascular bundle, sir.
So there is a neurovascular bundle there. So either there is an artery or there is a nerve. So there are only two things there. Either this is an aneurysm from an artery, or this is a nerve origin lesion.
Sir, if it is artery or any vessel, then feeding vessel or some sign should be there. Or
not necessarily. You might see something, a shadow, an aneurysm, for example. Even sometimes big aortic aneurysms, you cannot see shadows or feeding arteries. So it's a rare thing to have an aneurysm coming from the intercostal artery, but it's not rare to have a neurofibroma, is it?
Yes, sir. Yes, sir.
All right, I'll take you here. Look at this one. So there's a lesion underneath the rib. It is definite notching and rib excavation. And this is clearly seen here. So always remember, opacity adjacent to the rib with notched margins, consider a case of neurofibroma. All right? Yes. So what are the differentials? I will not ask you this, but always think that if there is a superior rib cortex resorption, you might think that it's a case of rib notching, but it may be as a result of pressure symptoms, right? So if you don't see any adjacent lesion, you can also mention that it can be because of pressure symptoms, like in this case where this patient has a scapular exostosis, hereditary exostosis. Another case of rib notching, you see this one, it's a unilateral superior rib notching, right? And the patient is, I'll give you history, the patient is quadriplegic. So this one is because of position. The scapula is pressing for a very long time on the rib, adjacent rib, and that's why, because of muscular atrophy and osteopenia, a patient can have this notching. A case of, this is a cone down radiograph, and this is a patient with osteogenesis imperfecta. And you see the ribs are gracile, they are thinned, flattened, narrowed posteriorly. So, especially this one. So sometimes other associated abnormalities can lead to rib abnormalities, not necessarily because of the localized.
This is a chest frontal projection of a 26-year-old male. And this is a pre-op X-ray for surgical procedure. I can see there is a opacity in the right hemithorax, covering up almost lower half of the thorax, and causing mediastinal shift towards the contralateral side. The visualized right lung appears unremarkable. The contralateral lung and CPL and left hemidiaphragm also appear unremarkable. This opacity on the right in the right hemithorax is not forming any meniscus sign, I think.
Okay, so what do you think it is? Give me three differential diagnoses that you think. Is it a pleural mass? Is it extrapleural, pulmonary? Do you think this is fluid? Or you think this is a lung tumor? What do you think? Or something else? So as I said, whenever you find you have a finding, look for the satisfaction of survey. Look for other things if you find anything. If you don't, then you come up with the differential list.
Right. Right. So now I'm looking for the overlying ribs of this overlying this opacity. Ribs grossly, I think I cannot see any rib destruction.
Okay. So this is the X-ray of the same patient about 2 years back.
2 years back. Okay. This X-ray showed the right hemidiaphragm is raised and with slight blunting of the.
Okay, so right hemidiaphragm is raised. Now this is after 2 years.
I think the previous X-ray finding could be due to eventration of the diaphragm and this and that eventration it might progressed and with addition of some effusion.
Okay, so now you have something in mind, eventration, and what else do you think it could be? If you think
I think it could be some underlying eventration with some underlying lung. Also
okay,
be collapse.
So this is very important. So you say this is eventration. I'll give you an additional finding which is important. And look at this. What is that?
Yeah, there are few lucencies.
Okay.
Of lucencies. This could not forming specifically related to the bowel. I think
okay.
I cannot
so
see.
There is a lucency. It is either bowel or this is abnormal gas shadow of some kind. So, can you correlate both findings?
Sir, I can give possibilities like there could be some below the diaphragm pathology like abscess or something that can further aggravated the diaphragmatic.
Fair enough, but you mentioned eventration. You remember? So when you say eventration, you cannot go straight away to an abscess. So if I'm pointing to a lucency, it's bowel. Let's say it's not an abscess. There is no history of fever. You say the patient has come up only for a pre-operative radiograph. So I did not mention the patient has fever.
Okay.
Right. So this is either interposed colon. So the colon has come up between the diaphragm and the liver, or the bowel is in a location where there is nothing else. That means the patient might have some sort of diaphragmatic pathology, as you already mentioned, eventration. But eventration will have, the border will not be like this, not this irregular. right? The infiltration border will usually be relatively, you say, well-defined dome shape. Okay.
Right.
Look at that.
Yes.
You see? So sometimes we all see what is there. There's a diaphragmatic defect, and the patient has traumatic diaphragmatic hernia. The whole liver has moved up, and what you saw there is because of a rent in the diaphragm with herniation of the liver. And this hernia was surgically repaired. Now, when the patient had urethral stenosis, this was because of a trauma, and the patient has traumatic urethral injury. And that's why a patient has a urethral stenosis. But this one is an incidental finding, all right? But quickly tell me the findings. What do you think? Within 2 lines, what's your diagnosis, if you think?
So briefly, if I add both the views, frontal and lateral, on the lateral view, I can see only one diaphragmatic line. Other diaphragmatic door is not visible laterally. So it means there is also some diaphragmatic pathology.
Very good. So diaphragm is a frontier organ. Remember, a pathology above that you see can come from below. This is why I'm showing you another case. You see there are abnormal lucencies. There is opacification. The left lung appears to be compressed. There is blunting and slightly irregular margin. You see sort of lucencies there. That lucency is either because of necrotizing pneumonia or a trapped lung, or because of some bowel. But when you see this, you don't see the margin of the diaphragm here. All right, there's something wrong with the diaphragm. There's lucency. That means this could be bowel. And this was another case of a diaphragmatic injury where there is a diaphragmatic hernia. Another case of you see a large opacity in the lower lung. The border is irregular. There's blunting of the posteroanterior. Not it's very blunt, but there is some opacity there. Again, now this can be a case of diaphragmatic injury or paralysis. Okay. But this one, the question is the right diaphragm abnormal or the left is abnormal?
I think if I see on the lateral view, I think right is
all right. So you know the left diaphragm disappears when it reaches the border of the heart, and the right one can be seen continuously. All right. It's a difficult radiograph to interpret, but you can see that there is an opacity projected over the spine, right? And so this can be either a pleural-based mass, it can be something in the posterior paraspinal location, and we don't know. This one is, you cannot diagnose it on the basis of X-ray, but you can raise and suspicion, right? This was a case of gallic hernia where a renal cyst actually was herniated above. Yes.
Hello. I'm provided with X-ray frontal projection and lateral projection of skeletally mature patient, in which I can appreciate that the cardiac size is enlarged. However, bilateral CP angles are clear. Bilateral lung fields appears normal. Trachea is central in position. On lateral chest radiograph, I can appreciate our radio opacity in the middle zone, and And left pulmonary artery appears to be bulky.
Okay. So what is your differential diagnosis? What do you think is going on with this patient?
There is massive cardiomyopathy with the right few reticular opacities in the right lower zone, curly horizontal lines, maybe curly V lines.
Okay. So are you pointing towards pulmonary edema?
Yes.
Okay. Okay. For all the residents who are looking at this radiograph, whenever you have this kind of a hard shadow, which looks so big, there are three things which come to mind. Sometimes this can be an Ont-Mini case. I'll come further to it. Okay, I'll take the case from here. We have left with half hours. So after this, I'll show you most of the cases myself so that you can see the cases. And okay.
Sir, the outline of the heart is very well demarcated, so it can be pericardial effusion.
Okay. Let me take it from here. That's a right comment. It can be a massive pericardial effusion. That is why I brought up this case. Most of the people will call this pericardial effusion, but only if you have an AP X-ray or a PA X-ray like this. Really, you have a lateral view here. And a 22-year-old, always remember that the retrosternal space is dark. It is not radio opaque like that. Okay, the spinal lucency becomes more towards the diaphragm, so the spine becomes more darker. The retrocardiac space is dark like that. Okay. Now, if you compare the retrocardiac space here versus here, there's something wrong here in conjunction with the heart, a large heart. So, why would a pericardial effusion cause the retrocardiac shadow to become opaque? So that's why we do a CT scan, because there is suspicion of a mass there. Sometimes patients who have mass arising from the anterior or superior mediastinum can wrap around the heart, and then they can exactly look like a case of pericardial effusion, but it will not cause the retrocardiac lucency to be lost. And that's why the reason of bringing up this case. This is a case of a thymolipoma, and a thymolipoma can cause an affair like that. If you have this CT scan in the exam, the differential diagnosis would be lipoma, mediastinal lymphomatosis. You can have teratoma. Now, lipoma, it will be well circumscribed. You will not see these soft tissue components, less likely to see them. The patient will have some sort of history of steroid use. If it is a lymphomatosis, usually it is unencapsulated, but that is associated with obesity and also in steroid use. Sorry, I mentioned that patient with lipoma will have steroid use history. No, it's in case of lymphomatosis. And if it is the case of a teratoma, then the patient will have calcifications and cystic components. Right, so there are three cases. This is a case of mediastinal lymphomatosis. This is a case of teratoma. You see calcification and androgynous components. Liposarcoma can also be seen as an intermediastinal or mediastinal mass, but that is more aggressive looking, and it will have local invasion and lymphadenopathy and metastasis and stuff like that. The Morgagni hernia can also be an interior mediastinal mass. So these are the differentials on the basis of that particular CT appearance. On the basis of the X-ray appearance, you will consider this number one, pericardial mesopericardial effusion. But if you have a lateral view, then you consider mediastinal mass. Stein's anomaly is one condition. Now, these are two different cases which I wanted to show you. This is a case of pericardial effusion. exactly similar looking case of Epstein's anomaly in a child, but the difference is the mediastinum. You see this is a thin and narrowed vascular pedicle, and there's the pulmonary vascularity on both sides is different. This one having a normal pulmonary vascularity, this one with a reduced pulmonary vascularity. You see the pacemaker positions. The pacemaker position, the lead position is different. That means the cardiac chambers in this child are very much larger than this particular case. So all the things that you see on X-ray point towards something. This is a water bottle sign, which is globular enlargement of pericardial slit, and this is a enlarged box-shaped heart of Epstein's anomaly.